Welcome, everyone, to LGBTQ plus health disparities in oncology, the epidemic no one is aware of, hosted by Bristol Myers Squibb and the National LGBT Cancer Network. My name is Paul Shea, and I'm the global lead for the Pride Alliance People and Business Resource Group here at Bristol Myers Squibb. I'm delighted to be joined today by Scout, who is the Executive Director of the National LGBT Cancer Network. Bristol Myers Squibb Pride Alliance and the National LGBT Cancer Network have partnered on some very important work to identify and address inequities experienced by LGBTQ plus cancer patients and survivors. Our talk today will discuss that research partnership and what is known so far about the health disparities faced by LGBTQ cancer patients. Before we dive into these topics, I'm first going to introduce the executive sponsor of Pride Alliance at Bristol Myers Squibb, our Executive Vice President and Chief Financial Officer, who will give an overview of our company and recent commitments we've made more broadly on health equity and diversity and inclusion. So please welcome David Elkins.
Thank you very much, Paul. I'm really delighted to be here today. As the CFO of Bristol Myers Squibb, I often get to talk to the investment community about the health of the company, the long-term potential, and our operating performance. As a member of the leadership team, I often get to talk to our employees about the performance of the company, but as well to thank them for their outstanding commitment and contribution to helping patients prevail over serious diseases. As the executive sponsor of the Pride Alliance, I also get to share my own personal commitment at achieving diversity and inclusion in the work environment and our own company's commitment and long heritage of investing and focusing in diversity and inclusion. At BMS, we are making bold steps in several areas, making a difference not just with patients, but with society as a whole. As a healthcare organization, we have an obligation to better reflect the diversity of our patients, customers, and our communities we serve. We recently announced a $300 million commitment to address health disparities and racial inequity over the next 5 years. And while $300 million commitment is new, investing in diversity and inclusion in all aspects of our business is nothing new for BMS. We have a legacy of promoting equity and working to improve health outcomes in populations disproportionately affected by severe diseases. But we know we can and should do more. We will focus on 5 areas to address inequity in our research, our communities, for the patients, and for our people. Addressing health disparities, we will improve access to care, help patients access and afford medicines they need, particularly among communities of color and populations disproportionately affected by the diseases we treat. We will also advocate for policies that promote health equity and address disparities in care. Clinical trial diversity is another commitment. We will extend the reach of our clinical trials into geographic areas in the U.S. that support underserved patient communities by building a clinical trial infrastructure and workforce development program to increase the diversity of our clinical trial investigators and better reflect the diversity of our patients. Supplier diversity has always been a priority for us, and we already have what I believe to be one of the most progressive supplier diversity programs in the industry. By 2025, we will aim to spend $1 billion globally with our diverse-owned businesses to increase the diversity of our supplier base and generate jobs and positive economic impact in the communities often hard hit financially by system injustices. Internally, we're going to provide a 2-for-1 match for our employee donations to designate to organizations focused on racial justice and diversity, and we will strengthen our focus on developing a workforce that reflects the diverse demographics of our patients and our communities, and cultivate a culture that promotes a sense of belonging for our workforce. These commitments will position us as champions of equality and a leader in an industry with the possibility to transform the lives of even more patients. The need for bold action has become very apparent over the past few years and was amplified by the recent events in the U.S., including the spotlight that COVID has shined on the systems that result in unequal treatment of Black Americans and people of color. At BMS, we have an opportunity to make significant impact on driving change and helping improve the health in the communities and the patients that we serve. And we appreciate the efforts and the work that you are doing to address health disparities in the LGBTQ community. I'm very happy to hand back over to Paul Shea, who is a great champion for inclusion, is really helping to make a difference in this space and within our company. Thank you.
Thank you, David. Scout, why don't you introduce yourself first?
Thanks, Paul. I'm Scout, as Paul had said, the Executive Director of the National LGBT Cancer Network. We were formed about 13 years ago, and our mission is really to educate our own communities about our cancer disparities and to train providers to do a better job of serving us, and then also advocate within the larger cancer community to make sure that cancer organizations are serving us. We do a lot of work with public policy around the country. We do a lot of work with departments of health, but we're very excited about this new project. And with that, Paul, you can introduce yourself.
Awesome, thank you, Scout. So as I mentioned at the opening, I'm Paul Shea. My pronouns are he, him, and I'm the global lead for our Pride Alliance People and Business Resource Group here at BMS. At BMS, we have a pretty unique model for our resource groups. My full-time job is to develop and execute a business plan that drives employee engagement, shapes our company's culture of inclusion, and delivers business insights and results, all by marshaling the talents and dedication of an all-volunteer organization. I'm about 1 year into this 2-year rotational development opportunity, and it's been a great experience, many learnings I'll take back to the business once I pass the baton to my successor. For those watching live, Scout and I are live on the chat to take any questions in real time, and we'll also be taking questions at the end. As I just mentioned, part of my responsibility is to develop a business plan to drive impact to our company and stakeholders. Here you can see a very brief summary of that business plan, organized by the 3 pillars we use here at BMS: workforce, workplace, and marketplace. Down below, you can see the individual committees aligned with the various elements of our business plan. Our topic today is on LGBTQ+ health disparities in cancer, and comes as a result of our business plan objective of enabling LGBTQ+ patients in BMS's core therapeutic areas to optimally engage with the healthcare system, prevail over serious diseases. Next slide, please. Before diving into the topic, I thought I'd share briefly how we were able to get to this partnership with the National LGBT Cancer Network. It started actually with a lot of outreach and cold call style introductions to external groups like the National LGBT Cancer Network that looked to be aligned with our goals of advancing LGBTQ health in BMS's therapeutic areas. We then had open-ended discussions with these groups about possible ways it could make sense to work together. In the end, we selected this opportunity based on the strong strategic fit in our objectives, the ability to make a meaningful impact in a discrete project relatively quickly, the ability of it to fit within our annual budget, and the mutual credibility we established with each other throughout these discussions. Once we had aligned on how we wanted to work together, I had to have a lot of internal conversations with stakeholders across BMS functions that might have an interest in such a collaboration to make sure there's alignment to support the work and no concerns. We did not expect any major concerns, but given that this was a rather novel partnership for our Pride Alliance resource group, we didn't want to make any assumptions. And as a true partner in this work, we wanted to find ways that BMS could support the success of this project beyond just providing the funding. Next slide, please. So this is admittedly not the most visually creative slide. I'm not the best when it comes to graphic arts, but the intent is to show the many internal stakeholder groups that we discussed this project with over time to gain alignment and identify ways BMS could support this work. And so you can see at the bottom that it didn't happen overnight. Initially, we talked to a limited set of stakeholders to make sure there were no concerns, and grew a circle of stakeholders we aligned with over time. Overall, it took about 4 months to build the internal alignment, but in the end, it was time well spent because we were able to identify internal collaborators who could support the project, leveraging their functional skills and work expertise as well. So with that, next slide, please. Now I'm going to turn it over to Scout, who's going to lead the majority of the discussion on LGBTQ+ health disparities.
Thanks, Paul. So I would say it's interesting from our perspective too, our half of this equation. It's not often you get a large company calling on your main line saying, "Hey, we'd like to maybe talk to you." And it's usually those are the the calls that aren't real, but this one really was someone who was very interested in trying to invest in this arena. And so we had a really good time as we first started to have discussions with Paul around what they were looking for. And then, of course, we went through a couple different items on our wish list of things that we wanted to see happen soon and things that we thought would be high impact. And we were very happy, I think, that we were able ultimately to find a fit. And the fit that I'm going to talk about now was also probably our top project on our wish list. And we've been looking at some funding opportunities that would have been slower for it. So one of the things for us that was really great is that this was a much more nimble and faster opportunity to get this project on the street and out the door. So with that, let me tell you a little bit about, first of all, the background and why that we thought that this was something that was important to do and what the need is. So as many people kind of ask us, when you're thinking about health disparities, how much does the gender of the person you're with really matter related to health? Like if you have a lump in your breast, does it matter who that lump spends Valentine's Day with, or is a lump a lump a lump? And of course, we're kind of trained a little bit in like a biomedical model related to health, which shows us that, a lump exists and you should treat all lumps the same, and that would be equity and equality. But of course, over time, in being in the LGBTQ plus health disparity world, we're able to talk to people about the fact that actually social determinants of health make a big difference, even in biological health processes. I think one of the examples that we see very vividly these days related to this is the differences as far as how COVID is impacting different populations. Those are not likely biological differences. They're differences having to do with access to care, welcome to care, how quickly people get to care, what kind of underlying health risks they may have, what kind of discrimination or disparity factors created that constellation of underlying health risks. So people are starting to understand that concept more readily now. But a lot of the work we do is trying to train people that you can't treat everybody the same, because that actually doesn't work for a population that starts out with a profile of discrimination, and as a result is particularly wary of the health provider system, for example. So if people are familiar with it, the cancer care continuum talks about how cancer may impact a population or person, all the way from risk, screening, diagnosis, through to treatment and survivorship. So while many of us haven't had cancer, all of us are at risk for cancer. So if you even look through this lens, you really are doing something where you're approaching the whole population, not just the people who may currently have or are survivors, but the people who are at risk for the health issue too. So what do we know related to discrimination with our population? Just as some examples of some notable points that are relevant to what happens with us with cancer. There was a study not too long ago that showed that 80% of first-year medical students expressed implicit bias against lesbian and gay people. It didn't even ask about bi or trans, which usually are populations that have an even higher level of stigma. So if you can imagine, these are the providers just getting into the workforce now. And that implicit bias is something that then will likely carry very far forward in their professional careers. And that doesn't even talk about the fact that the older people who are already in the workforce likely have higher levels of such bias. And almost 50% of the people in that study expressed explicit bias as well. So what is our number one health risk as a set of LGBTQ plus communities? When you ask people on surveys, we're very likely to say that our number one health risks are like HIV, mental health, suicidality, possibly addictions. And you get all the way down to number 10 in the list before people usually list smoking. But our rates of, I have a typo in there, but our rates of cigarette smoking are currently 40% higher than the general population. When you look at all tobacco use, it's gone up to 60% higher than the general population. So unfortunately, it's an example of how we have a profound disparity in a health area that actually creates a constellation and a cascade of health risks and adverse health outcomes. For example, one third of cancers would disappear if tobacco disappeared from the planet today. So you can see how this concept of us having a much higher level of smoking and tobacco use cascades towards cancer and a lot of other health problems as well. So epidemiologically, this is by far and away the number one thing taking years off of our community's lives, but unfortunately, we don't usually realize that that's the case. And actually, since the time we prepared these slides, some newer data has come out here. This is just an example of how youth are smoking at much higher rates than our LGB youth. They don't collect T on this study, unfortunately, are smoking at much higher rates than the general population. And you see there that the smoking rates are 16.2% for LGB compared to 8.1% for general population. So that means we are 100% higher at our smoking rates. The newer data that have come out continue to show that youth are 100% higher in cigarette smoking rates, but what's really different is the other half of the equation here. Whereas in 2017, this survey, which is called the Youth Risk Behavior Survey, showed that 17.5% of LGB youth were vaping. Right now, it's over 33%. So over 1/3 of our youth are currently getting addicted to nicotine via vaping. It's a huge increase in a risk behavior, that one of the biggest increases in a health risk behavior we have ever measured as a population, be it queer or mainstream population. And in case you don't know, usually the youth are getting addicted to this via the fact that the tobacco companies have flavored vaping products like cotton candy or apple teeny or things like that, which are very much kind of aimed at the youth. So it's important to think that when we have our vaping discussions, is it really about cessation? More of the impact right now related to vaping is how many of our youth are getting addicted to nicotine via this route. And flavors need to go to help change that. We also have a long history. This is a 2011 report that the Institute of Medicine put out related to access to care barriers. And that means that we are very likely to know someone who's had an adverse experience with a provider if we haven't had one ourselves, particularly if you're bi or trans, those risks are even increased. And it means that we carry a level of trauma in our communities and in our population related to how people have treated us in the healthcare environment that goes long beyond the actual particular events. So it's unfortunately something that even if the world around us might be changing, we come to each medical experience remembering our history of all the things that happened before. So the fact that we have all these access to care barriers often means that we are not as quick to go to the doctor around some things that we need. And we obviously have a harder time finding doctors that are welcoming. So what does this mean for cancer? As we had said, we have increased cancer risks, particularly related to the tobacco use, but also because of our access to care barriers, we have decreased screening rates. I was about to say something more about it, but I realized this slide about that's coming up in two, so I won't jump the gun on myself. So just as some examples of these decreased screening rates, research shows that only 44 to 56% of lesbians have regular pap smears, unfortunately. And one of the big issues, and there's another thing about this a little bit later, is that most providers do not even understand that there is an anal pap smear, which would be very important for HPV and for anal cancer in men. And they don't know how to perform it, even if they do understand it. So most often, if you are a gay, bi guy, or a trans woman, and you're having anal insert of sex, you go to the provider and they're not necessarily giving you a cancer screening that you really should get based upon the risk profile. There was a smaller clinic up in Canada that decided to do a research study on their own trans population to see what the cancer screenings rates were for their own population. And they were not completely surprised, but they were surprised at the magnitude of the difference. They found out that the cancer screening rates for breast cancer were 70% lower than the rest of their population for the trans people. And the screening rates for trans people for cervical cancer were 60% lower. And then the thing that particularly confounded them, because those first two findings might have been explained by the fact that, you know, if it's a trans guy, maybe you're not thinking to give that person a pap smear. But the third finding related to colorectal cancer, the fact that those screening rates were 50% lower was particularly surprising because, of course, everybody has a colon. But being a trans guy myself, I think that's very explainable. Every time we have to find a new provider, it means we put ourselves at risk for another provider who's not going to treat us well. And so, truth be told, it's pretty easy to avoid going to a new provider for another type of screening, or to get the colonoscopy or something like that. So I do think that's understandable, but it's still a huge difference between the general population and our screening rates. We have seen that there's a limited amount of promotion that goes out to our population to try and encourage this kind of screening. These are two great examples, but it's actually also a Canadian health project here. So too often we don't necessarily see ourselves in the health promotion literature that's out there. We don't see ourselves in larger cancer control campaigns, and that's definitely a miss. So what can I tell you about how our breast cancer rates for our population compare with the general population? Just to say, we have no idea. What about our lung cancer rates? We've got those big smoking rates, so lung cancer is definitely no idea. Okay, well, what about other cancer rates? Can you say anything about all these cancer rates? And the truth is, unfortunately, because we don't have the kind of data collection that we really want to have, oops, sorry, let me go back there for a second. Oh, no, we'll stay here. We don't know anything about those other outcomes as well. I'm going to turn it over to Paul to talk about this a little bit, but then we'll come back also to talk about what we can do to fill that data gap. Over to you.
Yeah, thank you, Scout. So as Scout drove home just now, there's not a whole lot known about rates of cancer among the LGBTQ population. There is some limited information now available, but that really hasn't been gleaned from studies directly of LGBTQ people on cancer. Instead, it's being gleaned from other studies that just happen to ask people about their LGBTQ status. Most research was focused on family systems, HIV/AIDS, and general health. And to date, there still has been very limited systematic efforts to identify cancer care needs in our population. And the main reason for this is exactly what Scout just said, the lack of data on our community that is systematically not collected in the healthcare system. Whether that's in a hospital system, at the doctor's office when you go visit your general practitioner, as part of health registries, or unfortunately even in our industry in clinical trials. That information is almost never asked, the LGBTQ status. And thus, it is very difficult to study our population still and to get real answers to those questions that Scout asked a minute ago. And so what we have gleaned, you can see here on the left, there are at least 7 kinds of cancer for which LGBTQ individuals are at high risk based on those other kinds of studies that I mentioned earlier. And they're listed there on the left-hand side. And so with that, Scout, I think I turn it back over to you.
All right. So I'm going to run back through a few more points related to what we noticed disproportionately in our population. One of them is, as I mentioned a little bit earlier, that the issue related to anal cancer has been called an epidemic by some, related to gay, bi men, and trans women. And this is because there's a high correlation between HIV positive people and HPV infection and anal cancer. So here we've got something that, reporters are calling an epidemic, and yet it's something that we probably haven't heard much about. And as I mentioned earlier, our providers don't even know how to screen us for. We do also know from some studies that we have worse survivorship outcomes often. Gay, bi, and trans men report more psychological distress after surviving cancer than their non-LGBT peers. And if you compare us to the general population, lesbians are twice as likely after cancer to report poor health, bi women are 2.3 times as likely to report poor health. We know, of course, that usually bi people have a higher constellation of health disparities and trans people have yet a higher concentration of health disparities. And then, like I said, across the spectrum, we start to see worse survivorship outcome. Compared with others, gay male survivors of prostate cancer report worse functioning, more severe bother, worse mental health, and greater fear of recurrence. Not even counting that for many prostate cancer survivors, they also can't get any information from their provider about what sexual functioning is going to be like for them, because the providers are trained to talk about sexual functioning for heterosexual sex. Not the same, right? So we find that even when we control for demographic and clinical variables associated with care, our survivors report lower satisfaction with cancer care, not just worse survivorship outcomes, but lower satisfaction with the care they get from the medical system. Not completely surprising, considering we walk in with a fear of how providers are going to treat us and a long history of getting negative provider interactions. And then here was a study related to trans survival analysis. So you can compare the trans or gender non-conforming survivors to the cis counterparts. We see that the trans survivors have more medical comorbidities, poor physical health. Gender non-conforming survivors have greater physical activity, greater alcohol use, greater depression. And the trans female survivors have a higher level of diabetes, higher level of cardiovascular disease. Again, you start to see these constellations of different health disparity problems. With that, back to you, Paul.
Thank you, Scout. You had started touching on this earlier in the presentation, but I think it's just important to emphasize, what we know about barriers to LGBTQ health equity. And our community, suffers from many of the same barriers to health equity as other marginalized groups. So, LGBTQ patients are underserved, marginalized, and stigmatized by past experiences. You've touched on that already. We often have health-seeking behaviors that are different from the mainstream. We have higher rates for many cancer risk factors, as was previously discussed. We are more likely to remain silent, unfortunately, on relevant health issues when we interact with healthcare providers. And we have higher rates of mental health issues as well. And on the provider side, many healthcare providers lack full information on LGBTQ healthcare needs or worth. Also, many lack culturally sensitive intake forms and resources as well.
All right, so as we talked about, what did we want to do? One of the things that we talked with Paul about is that back in 2011, we did a survey. It was a very small survey, and from it, we asked cancer survivors, LGBTQ plus cancer survivors, what is it you would like to tell your healthcare providers? And we actually got, despite it being a tiny survey and not as diverse as it needed to be by any means, we got a great wealth of information out of it. And if you think about it, we're doing so much more work these days around cultural competency trainings and so many forums, but we don't have as many places where we actually ask us, what is your experience in this forum, so that we can train people specifically to do a better job. So this was a chance to ask cancer survivors their experiences, and we got some great information off of it, like I said. The findings were really categorized in, I think, six or so categories. So I'm going to go through them here and talk about what was important to these survivors. First one they really wanted their providers to know was that stigma plays a big role in LGBT healthcare. And they gave a series of things that people should talk about. I mean, people should know and people should train themselves on with healthcare providers to make sure that they can avoid this. But if you're a healthcare provider and you don't think that this is the case, you're not understanding the experience that our population has. Second of all, the survivors were really clear. Your local healthcare environment determines your experience, and it's very variable. They talked about how if you were in a rural area, it was going to be much harder to find a welcoming provider. There were places where, your local hospital was St. Mary's, and so people would drive well out of their way in order to find another hospital that seemed more welcoming because they weren't sure if St. Mary's was. And there's places where, there's doctors' offices are kind of notoriously not great. You usually have more choices if you're in an urban environment. I was just talking with a friend a couple minutes ago who was talking about how living in DC, he has the luxury of having gay doctors all over the place. But even then, he admitted if he went through something like cancer, he probably wouldn't end up having gay or gay-friendly providers as all of his providers, because that's a time when you see so many providers so quickly. The next thing they really wanted us to know is that disclosure is often related to perceived safety. So it's one of the things we talk to the providers about a lot. If you haven't done anything to show us that we're welcome, then why should we come out to you? So we really try and put it on the providers first to be like, it's time to step up and show us there's some reason to feel safe here, and don't expect us to come out until you do. The next big theme is that respecting us means respecting our support teams. And, you know, I went through a personal experience with this. My mother, who is a lesbian, was in a situation where her partner was end of life unexpectedly. And despite the fact that this was not too long after there was that kind of presidential edict that you have to, you know, let the partner in the room and respect the partner, it was a really cold and horrible situation to see all the hospital staff. They would let my mother in the room with her partner, her fiance, and they couldn't get married at that time. I was in Florida, they weren't allowed to then. But they only talked with the sister, the estranged sister who'd flown in from halfway across the country. And since that was the legal next of kin, my mother suddenly got, you know, relegated to the position of begging the sister not to pull the plug on her life partner because that person held all the control, and my mother was suddenly just a junior purse player in the play. So as these things actually unfold, you can see how brutal they can be for us. The next thing is the pervasive expectation of gender conformity can be alienating. I think 2 words say everything about this: pink ribbon. You know, we've got pink all over everything from football players' socks to practically every mammogram you can imagine. And if you're a trans guy who needs mammography, then that means you have to walk into a bright pink mammogram and mammovan, and that really doesn't work. In the same way, if you're a lesbian who's getting like breast cancer surgery and your doctor's talking to you all about reconstruction and how to, and you're kind of like, that's not what I care about. You know, those kind of gender expectations don't always fit us. Next thing is that we as survivors needed more culturally appropriate support and information. One of the things we saw over and over is that people were not getting it. They had no access to it whatsoever. That's one of the things that we'd like to try and provide more of, but it is challenging because a lot of the social support happens on a local level, and it doesn't mean that you definitely know if you're in a social support group, if it's something where it's welcome to come out with all the types of your life and parts of your life that may be LGBTQ focused. So those were the main themes from our first tiny survey. And just now a note on population data. When I first started giving these presentations, there were fewer states here, but right now it's really kind of nice. We're having an uptick in the number of people who are disclosing being LGBTQ+ in surveys. So that's great. And it means that right now in the United States, according to the latest Williams Institute data, the number of LGBTQ people in the country is about 14.7 million, which is about the same number as these 3 states combined. And if you remember, we're a population, of course, that doesn't have our civil rights. We may have recently gotten some Supreme Court non-discrimination protections for employment, but that's not all of civil rights. So can you, it's a lot of what we say to providers is, can you imagine living in a world where the people in Georgia, New Mexico, and Rhode Island didn't have civil rights, but the rest of the country did? That's our experience. So understand our experience as you think about how we approach health. And just another example of how this number is changing over time. This is one of the biggest surveillance systems in the United States, the behavioral risk factor surveillance system. And this is how many people identified as LGB in 2017. Now look at the same year for the youth identification. Wow, it's really changing. And that's lovely for us. These numbers are shifting. How many of us as ID as LGBTQ+ is growing, and that could mean that we feel safer. That's lovely. But as we talked about earlier, we don't have this outcome data related to cancer. We have little tiny data snippets from other studies and related things. How could we get this outcome data? The real answer is It needs to be collected at the doctor's office and in the hospitals. So if you ever see LGBTQ as questions on an intake form, it usually means someone's fought to get them there. And when we get them on all the intake forms, we are going to unleash a wealth of information about our population. It's going to be a fire hose of new health data that's going to be really valuable for us. And what we see from some studies is most people will disclose. So with that, that's all our background. So with all that, when Paul came to us and said, well, what would you be particularly interested in? The thing that we came back as our #1 wish was, we'd love to redo that study, but bigger, better, more diverse, and get better information around what people are both experiencing now and what's important to them to talk to the providers about, and more detail than we got out of the original study. So with that, as Paul had said, we went back and forth talking about what fit the most. And this was the thing that for Bristol Myers Squibb also fit the best with what they were looking for to build their portfolio, particularly with their oncology emphasis and their patient access emphasis, things like that. So we, as a result, came up with what we are hoping is going to be the same thing to cancer survivorship in our population that like the National Trans Survey is. So we are actually, as we're recording this, we are about to launch the survey, and the National Cancer Survey is about to go live. But just to give you a sense again, we had that original study that, again, was like 11 years ago, something like that, 9 years ago, I'm sorry, 8. There we go, I get the exact number soon. But just to show you, again, kind of the limitations. It had 311 respondents. We got a lot of mileage out of it. We generated several peer review articles. We generated the report you see here, and we still use these data in cultural competency training today. But you can tell that A, it's getting a little old. B, so few trans respondents. It was too white. It was a tiny sample. So we had some real limitations, which is what really drove us to the idea of, if we can do this new and better and the right way and quickly, it's going to be super valuable. So with that, they agreed, and we started working on the new, bigger survey. So we have had several steps now since funding started. We recruited an advisory council. We developed the survey instrument. They marked it up to heck and back. We went through an institutional review board, and we are literally, tomorrow is the day we will be launching the survey from when I record this. So by the time you see it, the survey will be live. And we're hoping this time to get at least 1,000 participants. One of the ways we're doing this is that, we've got a great, very active, engaged advisory council of providers, survivors. I think actually listening to the survivor voices on this has been really educational, even as the executive director of the Cancer Network. I think if you were to ask me what I've learned, I feel like our social isolation, we create spaces where we're safer in the world, right? We live in a safer neighborhood. We work at a safer place to work for disclosing that you're queer. We have our friends around us. But once something like cancer upends your life and suddenly you're thrown into a place where you don't have safety anymore, I really learned from the survivors that I think there's a lot of people in our population who hold a level of trauma that's above and beyond the general population if they go through something like this, because of the kind of isolation and social fragility we have related to being part of a group that is so easily discriminated against. So there's a lot of people who bear scars that are pretty different than general population scars, even considering cancer is so disruptive by itself. And we have just, we finalized the instrument, we got the IRB approval. This is just a little snippet from the beginning of it online. So as of the time that this is out, you will be able to take this survey. And we've also got a lot of, I think, very cool social media images, shareables, things like that. We're going to be putting partner logos on these so that they can get them out on their own social media. We even have a plan that we're going to, with the state departments of health, anybody who can get 100 respondents from any state we will run a special data sheet specifically for that state so they can get LGBTQI plus cancer data specifically for their state. So we're going to be like, okay, throw down the gauntlet, get us the 100 respondents, and we'll give you customized local data. And then one of the things we're very excited about that actually just happened is we got a major partner with the Center for Black Equity, who are the organization that that is the kind of alliance of all the Black prides around the country. And they've been increasingly concerned about cancer for a while now. So they have agreed to come on as our partner, and we have a mutual goal of getting enough respondents that we can specifically create a sub-report of the main survey for the Black and brown respondents, which, as we can see, obviously, with the increased emphasis on the diversity of, not just the diversity, but highlighting the health differences of particularly Black and brown and Indigenous members of our population. This is something that we're really excited to do. These are the kinds of voices and stories that have usually been overlooked. So we're looking to bring more partners on as well, because it's going to take a lot of kind of like outreach to make sure we get all the places we want. So really, if there's one last thing to say to you, is that this survey is live now. We have the shareables. We will put your logo on them too if you're interested in putting them out. But we need people to help promote this, because we know right now that there's about 81,000 LGBTQI folks each year who are newly diagnosed with cancer. And that means that's all those voices, all those experiences that really haven't been heard. And this survey will be open through the end of the year. This is the chance for us to speak up and say what this has been like for us. So I hope that if we take anything away from this presentation, not only is it kind of a great example of how Bristol-Myers Squibb has built a portfolio and has started to engage and work with nonprofits in a really constructive fashion to both meet their corporate needs and also advance the needs in our communities, but also that you will help us make sure you promote this survey so that we get it out to as many places as possible. And then look for the findings come spring of 2021. Maybe then we could also possibly go out to eat, who knows. And with that, Paul, come on back. And this is, hopefully you've been asking us questions all throughout this, but as well, we will stay on through the end of this time to continue to answer your questions about anything and everything. And Paul, so you've seen this, you knew what we were gonna say, but you went through this process. And, you know, given that that's the case, and, you know, we're in the Out and Equal Workplace Conference here, what do you think this has as far as special impact for the people who might be looking at this? And what are the kind of lessons you'd like to see other corporations take away from the experience you had here?
Yeah, no, thanks for asking, Sal. I mean, I think one is just being open-minded about like new ways of working with you know, third-party groups like yours that we don't necessarily traditionally partner with, you know, in our industry. The second is also a lot of internal tenacity. I mean, there's a reason why I shared that one slide earlier on about like all the different stakeholders that needed to be aligned with in order to move a project like this forward. This isn't the kind of partnership that we normally undertake. And so it really required a lot of, you know, multiple conversations, multiple parties to explain why this was, you know, what our objectives were, why this aligned with our overarching mission, how it's tied to the overarching company strategy and objectives around patient and population health, how it's tied to our D&I objectives, really painting that picture for everyone so that it was easy for these internal stakeholders to say yes, move forward with the proposal. So those are two of the key learnings. You know, and I just want to say, you know, we've you know engaged in these conversations for a long time. I'm just so excited about this work and for the, you know, outcomes that we're hoping to get out of it, because I think, you know, by shining a light on the experiences of LGBTQ cancer patients, you know, the good, the bad, and the ugly, you know, our hope is to really raise awareness of some of the disparities they're experiencing and motivate the external environment, you know, our peers, players in the healthcare system, researchers, everyone to pay more attention to this issue, to advocate for change that makes the experience of LGBTQ cancer patients much better.
Yeah, I actually, I mean, I'm really grateful to the partnership in some particular ways. You know, we had been thinking about going to the government for a research proposal for this. And as we looked at the horizon on that, it was very likely to be 2 years, you know? So for
Right.
us, when you called, it ended up really meaning that the findings could be out at least a year faster than they would have been otherwise. But also, I do like the idea. I hope that, you know, as this project goes through, we bring really good value to you with your investment in a nonprofit. And that Bristol Myers Squibb is proud of kind of how this shows their true commitment to you know, D&I issues overall and this particular slice of the population. It's something where, you know, we would love to see this kind of work. You know, we hear a lot of stories of we're committing this much more money, you know, kind of thing. We're committing this much more, especially this year. So I really appreciate the fact that, you know, you're building partnerships on the ground to ask, you know, the organizations like us, okay, we may not know everything. What do you think is important to do? And then kind of, you know, as you say, jump through the hurdles to help sell what we think is important in your own organization so that, you know, we can get the gas to get it done. And hopefully, you know, it'll be something that makes you proud as well once we get to the end of it. And more importantly, we will really hopefully make an impact with our population's experience related to this topic.
Yeah, exactly. And honestly, at the end of the day, that's all we are
Right.
hoping for as well.
Right.
You know, it's just
Yeah.
better outcomes for LGBTQ cancer patients. That's the pure motivator for this kind of partnership, and that's all we could. If we can achieve that, we're all extremely
Right.
happy. In that
Then we can go home. We can go home.
Yeah.
All right, with that, we will leave you. Again, we will stay until the end of this time. But thank you very much for coming, and we really appreciate it. Please ask us more questions.